Welcome, I'm Dr. Tom Souza, and I'd like to thank the FTCA for inviting me to present to you today. We're going to cover the diagnostic clusters that you should know for some common conditions. We're going to go through the process in a way that will explain to you why we look at diagnostic clusters as more valuable than single tests. In fact, most of the tests that we do, orthopedically and neurologically, require that we do clusters. But what's important there is we have to know which clusters and what's that based on. So as we go through this presentation, we're going to try to cover some of those basics. But again, trying to choose which tests is sometimes a ritual. In other words, we don't choose. We just simply accept what's given to us. It may be that from a list of tests, we decide that we're going to perform the test simply because it's on an exam form, or maybe we do it just because it's what we're taught. Is that actually the value of the test that's being represented by that particular format? So although ritual is a good thing with regard to your confidence and your comfort level, and it's also good for the patient because if they see that you're organized, they're going to feel more confidence in what you're doing, is it actually what you should be doing? And in fact, given it takes a long time to do a history and an exam, wouldn't it make more sense to be expedient? And not just from the sense of saving time, but also knowing that what you're doing is evidence-based. And so what we're going to try to do is show you that most of the time, the tests that you've been shown as a student are to give you more of a coverage of the types of tests that are used because you're going to encounter them on exam forms. But this isn't about filling out a form. This is about trying to figure out what's wrong with your patient. So in this particular case, ritual may not be such a good thing. A lot of people use mnemonics, and I think the most obvious one that most people will use is a history mnemonic of OPQRST. That is just an alphabetical mnemonic, and it's giving you a list because it's alphabetical, not because it's the list or order in which you perform that question. So what we want to do is figure out, again, not necessarily a list based on a convenience, but we want to learn the list that is succinct for the disorder that we're looking for. So instead of, again, focusing on the exam form, let's look at it from the perspective of either a condition or maybe even position. There may be a way to test people in a particular sequence of positions. So when we look at clusters, there are really a couple of things we want to look at. Certainly from the diagnostic perspective, there's history and there's exam. And there are history clusters for some common conditions where there are no tests. In other words, we also assume sometimes, because we think of orthopedic and neurologic as mainly the tests we do, or lab tests, that there is a test for that. But there are common conditions we encounter that, in fact, have no tests, and it's entirely history. So we start with the history. We look for clusters there, and then we move into the exam, oftentimes just confirming what we found on the history cluster. But when we get to the exam, because we're convinced by tests that are lab tests primarily, for example, looking for high plasma glucose levels for diabetes, we assume there's a single test for whatever condition it is that we're looking for orthopedically, but unfortunately, no single test, most of the time, no single test is going to actually give you the diagnosis. In fact, most of this is based on a sequence that we're going to be discussing called sensitivity, then specificity, and then the cluster of those two things together to try to come up with somewhere between 3 to 5 different tests or 3 to 5 different history findings that will indicate that the person, if they have all of those, will likely have that disorder. So clustering is an important pattern that we use, but it's based on evidence. It's not based on convenience. And so as we start to go through these clusters, I'm going to show you that all the work has already been done. So as we go through, I'll give you examples, and toward the end, I'll give you the resources. And I'm going to give you most of the resources, but not all the resources, in an attempt to convince you that this is not necessarily hard work for you. The hard work has been done by others, researchers, who have decided to invest their time and energy into making our clinical lives a little bit easier. So let's go through some of the basics, and this for me is just the concept of how we approach things. I think it's very easy, and I certainly did so as a student, to think of tests and history findings, but in particular tests, as just a sequence of things that you do on an exam form. But most importantly, the mistake I think I made as a student is because those are testable, and the most testable are the ones with names attached to them, that there must be a named test for everything. And in fact, most of what we do orthopedically is based on those mechanisms of provocation, and those are primarily based on stretch and compression. But it also turns out that you may be finding structures that are involved because of pain provocation that in fact have no named test. So we can't rely on the named tests. In fact, we have to really step back and say, how do I organize those named tests? And we organize them based on mechanism of provocation. Now, what works well here is it's not just provocation in the test, but it's also the mechanism of injury. So as we look at orthopedic testing, what was the mechanism of injury? Likely that's the mechanism we're going to use to either provoke, or in some cases, we're actually going to relieve the person's pain. One of the easy mistakes to make is to think again with test names and forget the fact that regardless of where we are in the body, there are standard structures. And those structures include certainly bone, muscle, tendon, ligament, fascia, nerve, and that we have to know what pathologies each of those may be involved with. And if you started making a list of conditions for each of those structures, would you be able to list all of them? So it doesn't really matter, for example, that you may have avascular necrosis in the knee, and then it may be called Blount's disease there, but in the elbow it's called Panner's, and in the foot it's called Freiberg's or Kohler's or wherever it happens to be in your foot. That's not the issue as much as the condition itself, and how you evaluate it really wouldn't depend on where it is as much as what it is. So do this with all structures before you start to think about the tests that you're using. Because after you think of all these, then your next question is, of course, what are the history things that would indicate that the person has bone involvement? What would be the physical things that I could do? And of course, I'm usually thinking at this point, I'm going to be using an x-ray. And by the way, when you get to x-ray, one of the things you also have to look at is which view. And so it's not just take all the views, which ones are going to show the pathology you're looking for best, and do you need to move on to special imaging? Joint would be another example. Obviously, we deal with joints all the time, but it's not just subluxation. We have all these other possibilities, including capsulitis, infection, other forms of arthritides. And how are those evaluated? First on the history, then on the physical exam, and then, of course, is there an x-ray for it? Is there a lab test for it? So again, regardless, we still have to go through the history, we have to go through the physical exam that we can do on the joint, and then we have to decide whether this is a radiographic or lab evaluation or whether it involves special imaging. Same would apply for muscle. Here are a number of conditions, some you would think of, but what would you do with rhabdomyositis? Well, that's going to have to be a lab test, as would muscular dystrophy, as compared to some of these others that might be evaluated primarily on the mechanism and then secondarily on the physical exam. And everything applies for the remaining structures that we deal with commonly: tendons, ligaments, bursa, fascia. So I want to talk about a couple of terms that you hear about and probably memorize more than understand. And one of the problems, I think, is rememorizing something because you don't understand it. And what you don't understand isn't necessarily how the thing is put together, calculated statistically, but more importantly, what's its clinical use? How do you use that in evaluating a patient, for example? Sensitivity, of course, is something that we don't think about in these terms as much as we look at it on a chart. But sensitivity is really the first step in trying to figure out if somebody has a problem. So we're looking at a couple of different things. The first one is, why is there sensitivity, and what does that mean? If you have a test that's sensitive, it likely means it's going to be positive for different conditions, not one condition. And why is that? Well, we have an overlap of anatomy where structures that are close to each other are likely going to be challenged by the same mechanism. And so if we look at how we try to provoke and how we try to challenge that structure, for example, stretch or compression, if something is anatomically close, it's going to be affected and you're going to get a positive test for all of those structures. And then, of course, the next question is, what is the provocation? So is the provocation based on stretch or is it based on compression? Here's an example. So if we looked at the knee and we were saying, okay, I want to see if I can provoke pain by knee flexion. Then my next thought anatomically is, what are the structures that are going to be compressed when I put them in that position? So with knee flexion, a lot of the internal structures are being compressed, and all of them can produce pain. So that's maybe sensitive because it's going to provoke pain, but it doesn't tell you specifically which structure is involved. And sometimes what we don't think about is which of those structures are the most pain sensitive. For example, you might think, looking at this list, that it's the meniscus, but actually it isn't the meniscus, it's the retinaculum. And then the next thing we could think about with orthopedic testing is relief testing. So maybe when I put the person in this position, it's actually relieving their pain. So then I think about what structures are now not being placed under more tension. And then that would primarily be the opposite of what we're thinking about with pain provocation, which is it's going to be the posterior structures that have the stretch taken off. And then that might be a clue as to what underlying problem the person has. So orthopedic testing generally involves stretch and compression. And regardless of whether it has a name or not, we need to know anatomically what's being stretched and what's being compressed. And the other thing we know about that is they're almost always going to be on the opposite side. So in this particular case, if I'm flexing the knee, I'm stretching the anterior structures and I'm taking the stretch off the posterior structures. Now this would apply to nerves also. For example, you may think of testing in the cervical spine area and think of a couple of different tests that you might use, in particular if you're looking at plexus problems. So for example, thoracic outlet syndrome, most of the named tests that you've learned are likely to be tests of compression. Whereas if you were using a test like the upper limb tension test, you're using a stretch test. And based on the mechanism, you may not find a positive if you're not reproducing that mechanism. So we first think about mechanism of stretch and compression. We also think about the context of the test itself. In other words, is it intended to be a stretch or a compression test? Now, the other sequence we do in the history, though, is if the mechanism isn't there because it isn't a single event trauma, meaning it's insidious and there's no explanation, then what we're going to be looking for is some form of non-mechanical cause. And I've given a list here. We don't need to go through this, but obviously we would be thinking of potentially infection, stroke, acquired disorders, maybe a tumor. Regardless, when we get to the exam, what we have to find is dysfunction of those structures, and that involves the neurologic exam. So when we get to the neurologic exam, and we'll be talking about this with radiculopathy, what's its sensitivity? Because what we're trying to do here is what sensitivity does, which is it screens for the disorder, screens. What that means is you want to make sure you don't miss it, even though you may have found other things because they're sensitive anatomically. We want to make sure we don't miss that. So here's an example of sensitivity with regard to two ways of looking at it. One of them is, knowing we're not wanting to miss something, we can throw out a net that will catch more than what we're looking for. So if we're going to use the analogy of, for example, fishing, and I'm trying to catch a large fish, and I keep the net holes small, then I'm going to catch all the large fish. There's no way I'm going to miss them, but I'm also going to catch a lot of other things that are not the large fish. That's sensitivity. It's not specific to what I want, but it doesn't miss what I want. Then I can move to a more specific test. And here, I want to find the thing I'm looking for. I know it's in there somewhere because I'm not missing it. How would I then find the big fish? Enlarge the size of the holes, all of the small stuff falls away, and now I have the large fish. That's what specificity tries to do. And now you see the reason for why you want sensitivity first, then you want specificity. Let's use another example, just someone trying to find somebody at a train station. So you've been sent to pick somebody up at the train station, and you have very little to go on. So the sensitivity, which is you know you're not going to miss the person because it includes part of the description of that individual. If you're looking for someone and they happen to be a blonde male, then if you find all of the blonde males getting off the train, you're clearly not going to miss the person you're looking for. But there may be many. So how would you get specific and know that you have the individual that you're looking for? Well, let's say the specific clue that you're looking for is they actually have a tattoo, but unfortunately it's on their upper right arm. Well, the problem here is, what if they're wearing a shirt? So the problem with specificity is, although it will tell you what you're looking for, it will find what you're looking for, it may not always be visible. And that's the difference between sensitivity and specificity. So in that same search for that individual, sensitivity made sure that you didn't miss them, but you may not always be able to specifically find who they are because it may be hidden in some ways. So we're going to start with history clusters, and I think sometimes as a student, I was never led to believe that's where I needed to focus. I always thought it's testing, because testing always finds what you're looking for. In fact, it's usually the opposite. And what we're going to look at here are history clusters that are screening for conditions that are relatively common for chiropractors. So the first one we're going to talk about is headaches. And one distinction we would want to make with a patient with a headache is, are we dealing with a migraine headache? And sometimes with migraines with aura, because they have neurologic signs related to that aura and symptoms, it may seem as though they need neuroimaging. So this was a study done in JAMA looking at what cluster of findings would indicate that the patient had a migraine, not specifically migraine with aura, but at least migraine, so I know I'm not missing it. So when they looked at all the individual findings, they actually found they were pretty bad, using some of the things we'll talk about in a moment, which will include likelihood ratios. This is a great example. Even though it's history, the same applies to tests, where each individual finding by itself is not of much value. But there's a way of clustering these together that's done statistically that we don't have to discuss, actually. And there's a formal way and there's an informal kind of statistical cheat that can be used to do this. But if you take these and proceed with the process, you can actually come up with a cluster, in this case, of 5 different findings that if they're all present, you're pretty sure the person does have a migraine. And it's not trying to distinguish between with or without aura, just a migraine. In fact, even if you had 4 out of the 5, the chance of that being a migraine is pretty significant. This happens to be an acronym. They're not all acronyms, but certainly P for pounding or pulsating, the O stands for the duration, the U stands for unilateral, N for nausea, and D for disabling. So there is no test for migraine. We're actually left with this as our diagnosis. Now, you may say, oh, well, wait, I want to do all these tests to rule out migraine, but that's not our chore here. Our chore is to rule in a migraine and distinguish it from all the other common headaches. And in fact, this is a pretty valuable, time-proven approach. The next thing we can look at is dizziness. And here, what we're looking at are the cluster of signs and symptoms that would suggest that the person has one of the more common causes of vertigo. So vertigo, again, just kind of distinguishing, is more the spinning type of dizziness. Now here's what's interesting, and I want to make this point as we go through. Sometimes it's not just a cluster that indicates which tests, but also indicates which disorder. And so the first part here is it has to be spinning dizziness. And then the next thing that's actually most important is the duration. How long does it last? And then the next thing that's important to kind of try to distinguish this is whether there's any associated hearing loss. And with BPPV, benign paroxysmal positioning vertigo, there is not. There are other findings that are primarily discussed with the patient after you get that far, which is it provoked by certain head positions, which is pretty common with BPPV, in particular, turning to the side of involvement. So that's that cluster of signs and symptoms. Now, we can go on and do testing, and there are certain tests that are pretty specific for BPPV, but by the time we get there, the history has really directed us with a good cluster. Another cluster that I don't think people are aware of, because again, there is no test, is the history cluster for depression. And although you at this point in your education, depending on where you are, may not think that depression is something we deal with because we're not psychologists or psychiatrists, you're going to be wrong. Most chronic disease has associated with it some mental effect, and sometimes that's depression, and sometimes it's the other way around. The depression actually leads to those physical complaints. This is an important thing for us to understand. So if you look at this particular way of formatting this, you can see that the two top ones are not only part of this cluster of 9, but they also are bolded and the font size is increased. And so what's happening here is we're looking at priority based on the format that I'm presenting. We have to have 2 present. They're required. Why? Because they're the sensitive tests. So looking at sensitive tests first, making sure they're there, and then making sure that you have some specific tests. Now, you can see those are kind of divided into both physical and mental problems, but when we take this as a cluster out of the 9, we need 5. So basically, we need the 2 sensitive tests and 3 specific tests. So now you learned one of the other little rules with cluster tests or cluster history findings, and that is they're comprised of both sensitive and specific findings, but the sensitive ones need to be there for the specific ones to be of value. Most of the time, there are exceptions. Here's another one that I don't think is intuitive. So you may have learned that for patients with diabetes, you're looking for polyuria, polyphagia, polydipsia. And that's true for a type 1 diabetic. We're looking at a type 2 diabetic. And eventually they will develop those signs and symptoms if they're not managed appropriately. But we're trying to screen. And what does screening mean? Sensitivity. We want these things to find the patient, even though other things could be causing it. So there are a number of things that can cause fatigue. There are a number of things that can cause numbness and tingling in the distal hands and feet, and maybe fewer things that can cause a change in vision throughout the day. So what do we have? We have kind of 2 sensitive tests with 1 specific test, or history finding in this case. So this cluster, and that's the important part here, this profile of having these 3 things exist at the same time in the same patient, that's a great history finding. But we know in this case, we can figure this out by doing lab testing. But would you order a lab test if you had no suspicion that the person had diabetes? The history informs the exam, and if the history is this strong, you can pretty much conclude that you're going to get that lab finding, and then you can get a little bit more specific with other findings, primarily based on lab. So before we move on to a couple of other examples that are related to the spine, I just wanted to show you why I think most students get bored and confused by a lot of the statistical terms that are being used. Think of it this way. We're looking at tests. If we're looking at what's called a dichotomous test, we're looking at a test to be positive or negative. And what that is variable. So if you're looking at instability, it means the joint is loose, so the person has apprehension. If it's provoking pain, then it provokes pain or it doesn't, so it's either or. When you look at tests that way, they're measured in a study several different ways, most of these being based on sensitivity and specificity. But If you can think of a test positive as being related to three things: sensitivity, which is the proportion of people who have a positive test who have the disorder, and positive predictive value, which is kind of similar. So what is the difference between those two? Sensitivity, positive predictive value. Well, if you look at sensitivity, it's the proportion of people who have the disorder who test positive. When you look at a positive predictive value, it's the number or proportion of people who have a positive test out of all the people who had a positive test. So think of it as just simply a different perspective of looking at a positive test. And then when you look at likelihood ratios related to test positive, these are sometimes referred to as positive likelihood ratios. And what these do is change the probability that a positive test indicates the person has the disorder. So without getting into a whole lot of detail, because it's not usually necessary for your interpretation, when you see these three terms, they're all related and their focus is a positive test, either from the perspective of all the people who have the disorder, all the people who test positive, or the probability that if you test positive, you have the disorder. And then simply switch it around. So for a test being negative, we look at specificity, negative likelihood ratios, and also a negative predictive value. So again, if the test is negative, indicating you don't have the disorder, then if it's a specificity that you're referring to, it's a proportion of people with a true negative who don't have the disorder. A negative predictive value is the number of people who test negative out of all the people who test negative, and then a negative likelihood ratio is the probability that that negative test indicates somebody without the disorder. So they're all related. And then it turns out that most of the other statistics are related to sensitivity and specificity. So why would you look at any of these? Most of the time you don't have to, but when researchers are trying to test the value of a test, they have to think about the utility of it. So sensitivity and specificity are found in this study. And then if you want to find out if that test is affected by the context of where it's performed, like, for example, an orthopedist's office versus primary care, then how many people have the disorder is important, and that's prevalence. If you want to apply it to your patient, then you move on to likelihood ratios. And then there are a couple of ways of using single values to determine the value of a test, and that would be the test accuracy and something referred to as diagnostic odds ratios. So diagnostic odds ratios are basically dividing the negative likelihood ratio into the positive likelihood ratio. And the accuracy is taking all the true tests, the true negatives and true positives, the accurate tests, and then dividing them by the number of all the tests that were done. And those are sometimes helpful also in gauging an overall idea of the value of that test. So let's go into a discussion real briefly of looking at a patient with neck pain and arm pain or low back and leg pain. Now, in most cases, in an orthopedist's office and certainly in most primary care offices, they're going to assume that it's nerve root lesion, radiculopathy. Well, how good is the physical exam on that? Because remember, with this, we're going to have an orthopedic and a neurologic exam. Well, here's the thing. Based on diagnostic studies that are electrodiagnostic studies, in fact, not all of them have it on physical exam. In fact, the other thing to be careful about is very few of them actually complain of weakness, even though you can find it on the physical exam. So your first caution is do a full neurologic exam on anybody that has neck and arm pain or low back and leg pain. And if we actually look at the number of people who don't have any weakness, it's almost a third of people who actually have a nerve root involvement. And there are a lot of reasons why, but one of them is weakness isn't necessarily the first thing to show up when somebody has a disc lesion. It may take time. It certainly takes time to get to the electrodiagnostic studies. And it turns out the same thing is true for sensory findings. So what does that make them? It makes them not sensitive. But when you find them, it's specific. So if you find something related to a nerve root that's a myotome or dermatome, it can be specific for that nerve root involvement. But because it's not found in all people, it's not very sensitive. And that's a general rule of thumb when we're doing neurologic testing. So we're going to look at that dermatome idea, because another mistake people make is the difference between a patient's complaint and the objective finding. And so this was a study done by Don Murphy and Eric Hurwitz. And what they were looking at is patients who were diagnosed with nerve root involvement, and then looking back in their files and saying, how many of them actually drew a dermatome? So the mistake we make is we think that a dermatome is what the patient draws, but that isn't what a dermatome is. It's an objective loss of sensation within that. And you can see here that basically 70% of patients who had a cervical radiculopathy other than C4, which is uncommon, did not draw a dermatome. However, if you tested them for loss of sensation within that dermatome, the objective finding, that was oftentimes found. The same thing for lumbosacral, but the difference here is S1 is actually often drawn dermatomally, but the problem there is it's not specific, because it turns out that all lumbar radiculopathies may have pain down the back of your leg. So let's look at cluster findings for cervical radiculopathy and the cluster findings for lumbar radiculopathy. And again, let's start with the two sensitive tests, which is in this particular case going to be the upper limb tension test. And then we're going to look at a decrease in rotation that's less than 60 degrees on the involved side. Those are pretty sensitive. We want those for our cluster to be accurate, because we need all four, starting with the sensitive. Moving to the specific, we see that we have involvement of relief with the distraction tests, and we also have provocation with Sperling's tests. When we get the specific added to the sensitive, the cluster of these four is pretty predictive of somebody having a cervical radiculopathy. The same thing is actually true of the lumbar spine, with several findings. Now, the problem with this is that we can look at the sensitive findings, and it turns out that they're kind of variable. You'll notice something that says DOR, diagnostic odds ratio. And when you look at that, you have to understand it's a way of determining the value of the test in relationship to the other tests. So what's the most valuable test? If you also look at a couple of these findings, you'll recognize they would take time. For example, atrophy, and maybe even weakness of the ankle dorsiflexors. But if I can add all of these together, that cluster of the sensitive with a lot of the specific tests could indicate that the person, in fact, has a lumbar radiculopathy. So what we've learned from this, hopefully, is you can know when somebody has a lumbar or cervical radiculopathy when you have those specific tests positive. But remember, a lot of the tests are not sensitive, so that means you may not know whether they have a radiculopathy or not. And why do you care? Let's say someone comes to you with neck and arm pain or low back and leg pain, you decide to adjust them. You didn't know whether it was a radiculopathy or not, but you maybe had a high level of suspicion. You told the patient, and you may have said, it may actually get worse after the adjustment, let me know. Not that you caused it, because it was there. But if the patient wasn't told that, and then they went to an emergency room or a medical doctor and they did an MRI, and there it was, they're going to ask, did the chiropractor cause that? So in fact, it is important to distinguish between it being there and not being there, and expressing that level of concern to the patient. It's also true in older patients, trying to distinguish between those that have lumbar radiculopathy versus stenosis. And in so doing, there are tests actually for stenosis based on the fact that stenosis, central canal stenosis, can press on the spinal cord. And when it does, that is a myelopathy. And you've learned a lot of tests for myelopathy, which certainly would include Babinski's, Hoffman's, Oppenheimer's, all those other tests, pathological reflexes. You also know that hyperactive reflexes are found, and you also know that this is going to affect gait and coordination. That's all true, but those are all specific, which means you may or may not find those. Now, the sensitive part here is the one most people don't recognize, which is there actually is a sensitive test, which is called the inverted supinator sign. You can read how to perform it on the slide, but basically it's the brachioradialis reflex, however, a different response. And then there are a combination of history and physical exam findings that you can see here on this slide. People with, and these are older people with radiation into the leg, those that have more of an anterior radiation with neurologic findings and limited trunk flexion, those are the ones most likely to have a disc herniation causing radiculopathy, versus those that are stenosis, which have more posterior knee pain. They're less likely to have neurologic signs and symptoms and less limitation. So I promised you I would show you some resources, and here's probably the best one. They've done all the work for you. Now it takes a little bit of investigation, as you can see looking at this table on the right, that they've evaluated all tests. And this does need to get updated because this was actually published a few years ago. But they have in all of their tables, if available, reliability, sensitivity, specificity, negative and positive likelihood ratios, and a rating score. And this rating score is on the quality of the study itself. And then at the bottom, they actually have their own clinical summary for you. And you can see that they also describe how the test is performed with pictures. Here we can see a common thing that I think is unknown for most people is that sometimes tests are used for multiple reasons. And so they actually indicate what the test was trying to find, which in some cases was different than the other study, which would certainly influence its outcome. Let me give you a quick one. You guys will probably learn Kemp's test. Now, most of us would assume that's a test because it's rotation and extension to the site of involvement for a facet problem. But some people teach that as a test for a disc herniation. Well, that's a problem if you're trying to find one versus the other with regard to its statistics. Here's another one called evidence-based physical diagnosis. And this shows tables pretty similarly to what we looked at before, but primarily focusing on sensitivity, specificity, and likelihood ratios. They also show a ruler for all of the conditions that they talk about. And this is a good example of how to interpret a likelihood ratio, which is for a positive test, if it's 10 or above, that changes the probability that a positive test actually indicates they have the disorder by about 45%. And if the test is negative in trying to rule out that they have the problem, then anything that's 0.1 or less is pretty good at ruling out by changing the probability by about 45%. And another one called clinical prediction rules will show you the cluster for a number of different disorders that we look at. This one in particular looks at the cervical radiculopathy cluster that we talked about before, but also prognostication or prediction of improvement with certain approaches. For example, if you were trying to use mechanical traction for a cervical radiculopathy, or if you were trying to use manipulation, what is the prediction and based on what patient profile? So it's a valuable book from that perspective. In my text, Differential Diagnosis and Management for the Chiropractor, I take a slightly different graphic approach. And so I'm giving you just kind of an example of what that is here, showing the cluster of tests on the top that are the best at ruling in, the ones on the bottom at ruling out. So you can see the arrows respectively going up or down. And then next to that, the likelihood ratios and the probability change based on that single test or cluster of tests. And I want to leave you with that. As we look at some of the tests for the shoulder, for example, impingement syndrome, here's an example of 3 tests. We have the Kennedy-Hawkins test, we have the painful arc, and we have weakness of the infraspinatus. Now, if all 3 are positive, that's a pretty good cluster for impingement. It doesn't tell you specifically what structure, but subacromial impingement. Well, here's another example. Looks similar, but this is for full thickness rotator cuff tears. So notice something, 2 of the tests are the same. Painful arc, infraspinatus muscle tests. That makes them sensitive because they're going to be positive for either condition. So we have 2 sensitive tests, but we need a specific test. So for impingement, the slide before, we had Kennedy-Hawkins. Here we have the drop arm sign for a full thickness rotator cuff tear, but we don't know which one. So then we have to do further testing, which could include these tests for whether it's subscapular, supraspinatus, or infraspinatus. So hopefully you found this valuable. It's kind of a short discussion, but at least giving you a sense of how you approach diagnostic testing from the perspective of the names of the statistics that are used, and understanding that those statistics certainly have a lot of complication or complexity about how they're created in a study. But what we've learned here is their application for us, treating patients, is trying to find out what's wrong with the patient by first screening for that condition we're looking for, and then trying to get specific tests to also be positive. And then scientifically what they've done is provided for us these clusters. And again, those clusters are made available in the texts or resources that I showed you earlier. So hopefully this will guide you, and hopefully if you're interested in learning a little bit more about this, you'll refer to my textbook, which has a chapter specifically on this approach. And of course, in each regional chapter, we'll tell you what the clusters are. And for those of you who are interested, you can go to my website at coffeebreaku.com. The site name is The Evidence Informed Chiropractor, and here you'll find over 150 videos that I've done on a monthly basis on the most recent chiropractic literature. For FTCA members, the discount code is 3102, and the cost is $25 per year. Thank you again.